Prabhash.
Yeah, done.
Nice.
Wait a minute.
Dr. Prabhash, we can start now.
Yeah, good evening. I'm introducing my friend, Dr. Arun. He is the Assistant Professor of Gastroenterology, Department of Digestive Health and Diseases, Chennai. The visiting consultant in Wildroth Hospital, Chennai. He is the Director of Chandra Gastro Liver Clinic and Endoscopic Center, Chennai. His area of interest is post-liver transplant, immunosuppressive guidelines, plasmapheresis in ACLF. He is the life member of ISG, INASL, SGEI, and IAP. Arun, please take over and present the hepatic encephalopathy.
Thank you, Dr. Prabhash, for your very brief introduction. And good evening, respected professors, senior consultants, and my dear friends. It's a really great, joyful pleasure for me to meet you all once again in this wonderful rainy evening to discuss something about hepatic encephalopathy, which is happening most of the time in the patients with liver disease. And before starting the discussion, I would like to talk something about Dr. Prabhash, who's one of the leading senior lead consultant neurologist practicing in Apollo Vanagram, Chennai. He's one of the close friend of me. And without him, the discussion won't be complete today. And I would like to thank Prabhash, and also I would like to thank Sun Pharma, who gave me a chance to be a part in this forum. And to discuss about the main area right now, hepatic enceph is, so if you want to discuss something about that, it's one of the very complex area to be discussed, and very frequently you'll be encountering in your practice day in and day out about hepatic encephalopathy. Because many physicians, this is my area to talk more to the physicians, also to the practicing gastroenterologists, also to the training PGs who are being in this field. And the main intention for me is, see, how will you recognize a patient with hepatic encephalopathy at a earlier presentation? And because once a patient develops overt hepatic encephalopathy, which means the patient is going to stupor state, the patient is being comatose. Once a patient is being entering in that state, doesn't matter. I mean, at that point of time, if you're going to diagnose, most of the time, the chances for the recovery will be very low. But when you're going to diagnose hepatic encephalopathy, the initial presentation itself, that it's a main area for us to be taking the lead for the discussion right now, to identify the patient with evidence of covert hepatic encephalopathy or minimal hepatic encephalopathy features. What are the areas is that should be discussed? And hepatic encephalopathy, if you are going to think about that, it is a it's a reversible neurological dysfunction, which is going to happen in a patient with liver cirrhosis. It's a neurological dysfunction in the form of altered mental status to deep coma, in complicating, which is being going to be complicated in the presence of acute or any other evidence of chronic liver disease. So to discuss briefly about the history, so right from before the birth of Christ, the discussion about hepatic encephalopathy has been started by Hippocrates to describe the association between jaundice and acute behavioral disturbances. And there are many more history, and to describe something about Morgagni, which are well known about the Morgagni's Lennox cirrhosis, who was a man who consumed alcohol, who misused, and followed by there was evidence of hepatic encephalopathy and the evidence of agitation. And there are so many history which is being there to be discussed, and moreover the 1 hour area to discuss something about hepatic encephalopathy will not be adequate, because it's such a voluminous area, it's such a lengthy area to clinically predict how will you manage, what is the path of physiology of hepatic encephalopathy, and how to recognize the complications, how to recognize the presentation, how will you manage it the earlier way, and what is the indication for various modalities of other line of treatment, what are the new innovations in the field of hepatology to discuss something about hepatic encephalopathy, and what is the role of liver transplant. There are so much of areas to be discussed in a short period of time, so I need to rush up my discussion, but the main area but I would like to enlighten the main area, what we're supposed to know right now. So the term hepatic enceph has been coined by Fazekas et al. In 1957, and it's also been minimal hepatic encephalopathy has been identified by Squammerus and Amster at around 1998. So as I discussed with you, is a irreversible, it's a reversible neuropsychiatric state of brain dysfunction. That is the main entity for me to discuss. And next to that, it can be predisposed in multiple conditions. It could be because of hepatocellular failure, or it could be shunt process during the shunt, because if the shunt is not going to function well, the fulminant hepatic failure, cirrhosis, a portocaval anastomosis, a post-tips patient, this kind of pathology can be there for a patient with hepatic encephalopathy. So the main area is how many percentage of patients. See, if you're going to talk about liver, either the patient is going to present with evidence of compensated cirrhosis, or the patient going to present with evidence of decompensated cirrhosis. Once the patient is going for decompensated cirrhosis, there will be around 16 to 20% definitely will be having evidence of hepatic encephalopathy, and moreover, 30 to 40% of the patients will if the patient is going to have cirrhosis, 30 to 40% of the patients, there is high possibility for them to go for hepatic encaph and overt hepatic encaph, which means stage 2, 3, and 4 and above. The overt hepatic encephalopathy can happen around 10 to 14% of the patients in general. As we all well know, TIPS is one of the bridge therapy before liver transplant in a cirrhotic patient. If you're going to plan a patient for TIPS therapy, that is also higher chances for the patient to go for hepatic encephalopathy at the rate of around 10 to 50%. And covert hepatic encephalopathy, which means minimal hepatic encephalopathy with evidence of stage 1 hepatic encaph, is nothing but covert hepatic encaph. There will be high possibility for this to happen. Around 20 to 80% of the patients can present. And don't think that once a patient presents to you with evidence of hepatic encaph and once you start the treatment, after that everything will be okay. Nothing like that. Once a patient even becomes stabilized and followed a period of time, the patient can develop a bout of recurrent hepatic encephalopathy. Also, at around 40% of the patients can develop a bout of HE, recurrent episodes. So this is about as per the AASL deposition statement, also per the EASL guidelines. So hepatic encaph right now being classified as overt as well as covert, and then the type A, B, and C that I'll be discussing in my upcoming slides. And overt encephalopathy is very easy to recognize based upon the clinical presentation and based upon the common bedside investigations. As I discussed with you, the prevalence is almost around 30 to 40%. But covert encephalopathy, how is it possible for you to recognize? Because the neurological part will be fine. When you're examining the patient, the mental status will be fine. But you should recognize there are so much of tests there nowadays. The innovation in the field of hepatology has been grown up. So there's so much of tests there. So battery of tests there to identify the abnormal psychometric evaluation. So which will predispose to around 60 to 80% of the patients for hepatic encaph. So this is a recent nomenclature as per AASL statement. So if you want to define hepatic encaph, you need to remember three major things, whether it is type A or B or C, or whether it is episodic or persistent or recurrent. Simple. So always you should remember, if it is type A, it will be associated with acute liver failure. The patient will be having acute liver failure, followed by the patient will be developing features of HE. In this presentation, the pathogenesis will be slightly altering. The chances of progression of cerebral edema, the chances of accumulation of ammonia will not be very, very characteristic like what's happening in a patient with cirrhosis if the patient is going to present to you with evidence of acute hepatic failure. But in type B, if you're going to have a congenital systemic shunt or portosystemic bypass, but there is no evidence of any intrinsic hepatocellular failure, in this kind of patients, you can also develop hepatic encephalopathy. That's nothing but type B. And type C is very common entity if you're going to develop hepatic encaph in the background of cirrhosis and in the background of portal hypertension. As we all well know, the portal pressure is going to be high, the wedge pressure is going to be high, along with that, the evidence of splenomegaly, varicose bleed. That's a point for portal hypertension to be assessed. So once a patient is going to be in type C, whether it is episodic, which means one episode in a period of 6 months, or whether it is recurrent, more than one episode in a period of 6 months, or whether it is persistent, which means the encephalopathy will not be touching the baseline and most of the time will be presenting. See, if you're going to see this graph, which means persistent encephalopathy is nothing but most of the time the graph pattern remains still in the higher line, which doesn't touch the baseline. So how will you diagnose hepatic encephalopathy? See, this is the basic definition. And if you want to have a diagnosis about hepatic encephalopathy, there are so much of criteria being used. And my intention to brush up your knowledge about the basic few criteria like West Evans criteria. So West Evans originally proposed by Kohn et al. And in 1978, it's most widely, but the problem is this West Evans criteria, there will be having an inter-observer variability. If you're going to look into that, see, always you should remember stage 0, 1, 2, 3, and 4. And stage 0 and 1 will be taking over into the covert features of hepatic encephalopathy, and 2, 3, and 4 will be taking over into the features of overt hepatic encephalopathy. So always based upon the level of consciousness, your intellect and your behavior, also upon your neurological finding. I think Dr. Prabhash is going to give a brief outline about this neurological finding. So, so based upon your level of consciousness, if you're going to think if the patient is normal or lack of awareness, followed by this comatose status. And what about the intellect? See, always you should remember, regarding the intellectual behavior, most of the time the patient will be having a short attention span. If you're going to talk something to the patient couldn't able to follow, they'll be thinking about something and they will not be able to reproduce what they're going to say, and they couldn't be able to reproduce a place, they couldn't be able to reproduce, things, what they've been using, and they'll be having a slow slur of speech most of the time, and the sleep latency is going to be come down, and the patient will be having abnormal sleep pattern. There are so much of things is going to happen before the patient sets into a comatose and stuporous state. And next to that, the neurological examination, always you should remember the classical presentation of asphyxis, that means flapping tremor will be more common. Will be more common in the patient with West Evans stage 2 rather than, but it can also happen in 1 and 3 also, but in West Evans stage 2 it's more characteristic. And once a patient is going for stage 3 hyperreflexia, that means decorticate posturing is going to ensure, which means followed by one patient going for stage 4 decerebrate, which means the final stage is going to set in before the patient is going to die. So this is about the outline, about the basic. This is about sonic classification, nothing but spectrum of neurocognition in the patient with cirrhotic background. So this is another new classification, what have been used in multiple newer textbooks like skip and slicing, what they've been considered about that. This is nothing but from covert to overt, what they've been discussing, the cognitive dysfunction and reduced level of consciousness as the stage is progressing. This is the same thing what I've been discussed with you. And next to that, this is what the previous means, there's episodic, recurrent, and persistent. And there are other scoring systems apart from this West Evans criteria, what we are frequently using. And next to that, about sonic classification, that covert and overt hepatic encephalopathy. And there are one more classification, what is called as HESA. That means it's nothing but, see, these are all very brief because I want all the PGs to listen to this area, because hepatic encephalopathy storing algorithm, because this separate entity can be asked most of the time during the exams. So hepatic encephalopathy scoring algorithm is ideally classified by Hasanin et al. And always it will be having a low inter-observer variability. And see, what is the reason for using this HESA? If you're going to be taking 4 components into an account, I don't want to discuss each and every component, but it's mainly based upon the clinical assessment and neurological assessment, and followed by the hepatic encephalopathy grade determination. So you need to see this, whether the patient fits into stage 1 or 2 or 3 or 4 before discussing the management of hepatic encephalopathy. This is another interesting entity, what I've been discussing, and a few days before also I've been discussing to some of my pages about clinical hepatic encephalopathy staging scale is nothing but chess. So even the recent guidelines have been mentioning everything about the chess. It has been coined by Oritz et al. To improve. It's been slightly the improved area for West Evans criteria. So it is going to be used West Evans, also the Glasgow coma scale. As we all know, Glasgow coma is nothing but 3 major entities: the motor, the verbal, the eye opening. It's very easy to recognize. The lowest score is 3, the highest will be 15. Always it should be in fingertips for most of us, and incorporates the WHC and the Glasgow coma scale, which is going to run between the 0 to 9, which means 0 is normal and 9 will be the patient will be in a comatose phase. So it's very easy to administer. So if you're going to see this chess, this is the same thing, but the question pattern will be very simple. But how many patients we have been looking into that? How many times we have been diagnosing? How many practitioners have been using this kind of scale? And if you are going to download this scale and you are going to use in a daily routine practice, I think you can able to recognize covered features of hepatic encephalopathy, and rather than patient to progress to overt hepatic encephalopathy, we can able to recognize the patient the earlier presentation, which means we can have very simple questions like which month the patient belongs to, which day the day belongs to, like that. So many simple questions are being there, and you can have a look on this flow chart about the clinical hepatic encephalopathy staging scale. So next to that is modified orientation log, which is a new addendum in the field. It's nothing but it's usually been used in case of traumatic brain injury, but there is a modified, it's mainly based upon to define the severity of hepatic encephalopathy. And this is a this is a condensed area to discuss what are the various staging systems like West Evans, hepatic encephalopathy, CHESS, and 4. What do you mean by 4 score? That is also been used mainly. 4 means the full outline of perspiration, which is going to be used. 4 score, if you're going to do, means the time required duration will be around 10 minutes. There are, see, all the scores can be used chances, but most commonly what we are going to use is nothing but West Evans criteria, HESA scoring, and apart from CHESS and 4 can be considered. But most of the time, the patient's time limit of doing this test will be around 10 to 15 minutes or 20 minutes. So the main area of our interest to discuss right now about the pathogenesis in hepatic encephalopathy is such a complex phenomena to be understood. As we all well know, right from undergraduate to postgraduate to specialty level of training, see what we have been understood about the basic pathophysiology is nothing but the ammonia effect. So what's going to happen in case of ammonia? What is going to happen if the intestinal dysbiosis is going to set in, the neurosteroids, genetic backup, benzodiazepine hypothesis, and so many years to come when we are discussing something. This has been a newer thing, new addendum in the discussion of hepatic encephalopathy about the pathophysiology as nothing but so what's going to happen if the patient is going to develop hyperammonia, ammonemia, and followed by the patients having impaired lactate metabolism, energy metabolism is going to be impaired, oxidative stress, systemic inflammatory pathway, and those things I'll be discussing in my upcoming slides. Okay. So regarding the intestinal dysbiosis, suppose if the intestinal bacteria is going to get overloaded, which means a short bowel syndrome, if any of the problems is going to set in, that will predispose to bacterial overgrowth, and followed by the bacteria is going to contribute the production of ammonia. So to discuss about the ammonia, which is a main key neurotoxin being involved in the pathophysiology. See, simply I will tell you about what the ammonia is going to do. See, regarding the ammonia pathophysiology, suppose if you're going to take a non-nitrogenous substances, so what is going to do, it will be converting into the proteins and through in the colon. So what is going to happen? It will going to release the ammonia through the proteinaceous products. So once the ammonia is going to release, what is going to happen? This ammonia is going to be uptake into the liver. Once the liver is going to uptake the ammonia, what is going to do? It is going to metabolize further, because the urea cycle, as we are well known right from your basics, the urea cycle disorder is well known in pediatric age group. There are many enzymes pathway have been involved in that, right from ornithine, citrulline, phenylacetate, glutamate, so many pathway, phenylbenzoate, so many things, arginate and arginosuccinase. We can talk in whole day and night about the urea cycle disorder itself. So once through the urea cycle pathway, this things is going to be metabolized, this ammonia is going to convert to urea. And what is going to happen if the urea is not going to be formed, and if the urea is not going to be eliminated through the kidney? So what is going to happen in the patient with liver cirrhosis? The ammonia is going to build up in the liver, and it is followed by the ammonia, it's going to increase in the bloodstream. Once ammonia is going to be increased in bloodstream, what is going to happen? It is going to cross the blood-brain barrier. Once ammonia is going to cross the blood-brain barrier, it will predispose you to cerebral edema, which causes astrocytes. Astrocytes is nothing but it is main substrate which is being involved, and if you want to discuss something about the astrocytes, it provides key nutrients as well as mechanical support for all the neurons, and it also involves the ion transport and the neurotransmitter uptake in the brain. And see what's happening once the astrocyte is going to be affected, what happens is going to be predisposed to cerebral edema and osmotic demyelination and cerebral lysis. And this kind of thing is going to set in, and the patient is going for cerebral edema, and finally the patient is going for hepatic encephalopathy, worsening of states and comatose and death. That's going to ensure. So the main pathway is ammonia pathway. Once the ammonia is going to raise in the brain, what is going to happen? The ammonia is going to get converted to glutamine. This glutamine is going to increase in case of once the glutamine is going to be more accumulated in the brain, which will predispose us to osmotic cerebral edema and other complications to set in. So this is a basic pathophysiology about the ammonia, urea production impaired and followed by the glutamine accumulation. Ammonia is going to be metabolized to glutamine. This is the basic pathophysiology. See, what is this ammonia sink? Is nothing but the ammonia keeps on producing, which produces a toxic effect in the brain, and followed by excess of glutamine is going to be accumulated. It's nothing but the ammonia sink pathway is going to be activated most of the time in patients with hepatic encaphalopathy. And there are certain new concepts about this ammonia, what they've been discussed. Once hyperammonemia is being there, the translation process is going to be affected, the protein modification is going to be affected, the ribosomal activation is going to be affected, and followed by the patient many translational modifications and other things is going to happen, followed by many neurotransmitters is going to be released. And there are so much of pathophysiology have been discussed about the ammonia hypothesis, and it also causes the alteration in microRNA. See, there are so many new innovations that have been discussed. Daily, so much of new pathophysiology is being coming into the discussion about. So even it will be involving the alteration of microRNA and other things to produce a pathophysiology of hepatic encephalopathy. That's the main neurotoxic effect of ammonia. This is how the simplest diagram. See what is going to happen. The glutamine is going to accumulate, followed by astrocyte swelling, and cerebral edema is going to get ensured in case of ammonia toxicity. It is going to set in case of cirrhosis. So what are the pros and cons about this ammonia? See, if you're going to think about the pros, which means the GA bleed, which will predispose to the increase in ammonia, which will predispose to hepatic encephalopathy. But what are the cons? Suppose if you're going to inject a patient, what are the cons in that? If you're going to inject a patient with ammonia, doesn't mean that you're going to have evidence of hepatic encephalopathy. And there are certain hyperammonemic urea cycle disorders. We all know not all the patients going to predispose to hepatic encephalopathy. And so you should know that even the ammonia doesn't going to influence the prognosis. It doesn't going to depend upon the stage in which hepatic encephalopathy is going to present. But even then, ammonia is going to have the prognostic importance of ammonia is still a questionable issue to be discussed. Apart from that, multiple other theories are there. One is because of inflammatory theory, and multiple other theories that can be considered in the pathophysiology of hepatic encephalopathy. So inflammation is nothing but once the patient is going to develop a systemic inflammatory response syndrome. So what is going to happen? The patient is going for SARS, sepsis, severe sepsis, organ failure. The patient is going for death. And followed by, there are multiple predisposing factors like alcoholic hepatitis, ALF, and other things is going to ensure once the inflammation is going to set in, various markers, inflammatory markers is going to get released, like tumor necrosis, interleukins, all those things which will be disturbing your blood-brain barrier, and it is going to increase the diffusion of ammonia into an astrocytes, which will also predispose the neurosteroids release. So once the neurosteroids is going to be activated, what is it going to do? The GABAergic pathway is going to be inhibited, other things is going to set in. So if you're going to see the increased blood flow, what is going to do? The blood-brain barrier is going to get disrupted, the lipopolysaccharide activation is going to be there, and neuronal dysregulation is going to set in the pathophysiology of hepatic encephalopathy. This is nothing but a neurosteroid study. This has also been discussed. So what is going to happen? The neurosteroids, so in ammonia, they want to say inflammation, there will be increased evidence of ammonia. Once ammonia gets increased, there will be increased evidence of neurosteroid like TPSO is going to get formed in that. And this will be predisposing to activation of tricarboxylic acid cycle, and also it increases the level of GABA synthesis. Once the GABA is going to neuroinhibitory factor, so the hepatic encephalopathy is going to set in. So, that's why there are GABA receptors, antagonists, and so many other drugs being tried in this entirety based upon the neurosteroids theory also. And this is one interesting theory, is nothing but oxidative and nitrosoactive stress. So what is happening? So once a patient is being having high levels of ammonia, the patient will be having evidence of activation of ROS and NOS, RNS is going to be there, which means reactive oxygen species and reactive nitrogen species is going to be activated, followed by what is going to happen? The patient is having astrocytogenesis. Once the patient is astrocytogenesis, what is going to happen? So see, if you're going to treat a patient with hepatic encephalopathy, but even then the patient is not going to improve much. And once the patient being improved with the basic symptoms, and when you examine the patient will be having minimal inhibition. They will be having long memory is going to calm down. The response inhibition is not going to be there, and followed by the learning capacity activity. Everything is going to come down most of the time, even if you're going to treat, which means the astrocyte is going to senescent permanently most of the time. That is a main mechanism. This is nothing but a Trojan horse hypothesis. What is a Trojan horse? The Trojan horse is nothing but a Greek mythology, which is going to be, this is being a wooden horse statue. It has been completely engraved in that. Like this, once a glutamine keeps on accumulating, once ammonia builds up, once the glutamine keeps on accumulating, so in the cytoplasm followed by mitochondria, what is going to happen? It is going to release multiple tyrosine residues, alter the intracellular patterns, alter the intracellular proteins. It is going to affect the transcellular substrate in your brain, followed by it will be predisposed to osmotic overload, that will predispose to cerebral edema. This is nothing but a Trojan horse hypothesis, which is being frequently asked most of the time in our exams during a preparation. So apart from that, manganese theory, this is not much of use. If you are going to manganese, if you are going to develop, if it's going to deposit in your basal ganglia, that will also predispose to Parkinsonism-like features. Another clinical picture can be happening in manganese theory also. These are not much of issues to be discussed. And genetic theory, if there is any polymorphism in the glutaminase gene, which is a key component in the metabolism of glutamine, if there is any polymorphism, if it is going to happen, that will also going to predispose to hepatic encephalopathy. Those are all the other things to be discussed. So there are many new entities which have been given in the newer guidelines. What is the bile acid pathway? So if you're going to discuss about the bile acid, so the main thing, the bile acid, if the patient presents, suppose if you're going to treat a patient with metronidazole, or if the patient is going to be treated with lactulose for the evidence of hepatic encephalopathy, this bile acid is going to be a substitute, will be going to involve the secondary pathway of bile acid production, and this bile acids will be increasing in the patient with hepatic encephalopathy also. That is also the main predisposing factor. Sometimes these things have been involving, and apart from the neurotransmitters, various neurotransmitters like NMDA pathway activation, so many protein receptors, so many pathways are being there, and brain energy metabolism. See what is going to happen if there is evidence of glycolysis, if there is evidence of insulin substrate is not going to be functioning well. These are so many brain energy metabolic factors, lipolysis and other things, which will also predispose to cerebral edema and other complications, and blood-brain barrier permeability also may worsen cerebral edema and other complications to set in. And these are all the newer theories been discussed, and very old there is not much of fashion nowadays, but even then some drugs are being still available in the market for this kind of theory, GABAergic theory, and followed by flumazenine and other drugs can be discussed, and benzodiazepine theory, GABAergic and GABA receptors and so many other things is coming. And this is false neurotransmitter amino acids, which means hypothesis what is nothing but the aromatic amino acids should not go high in our body. Only the aliphatic amino, the branch chain amino acids has to go high. That is why we need to substitute the patient with BCAA. If the aromatic amino acid, if it is going to go high, what is going to happen? It is going to form a false neurotransmitter that will also predispose to neuroinhibition. So these are all the various old theories being used in the pathophysiology of hepatic encephalopathy. But now, once you are going to discuss about the clinical presentation about hepatic encaph, is nothing but, so mainly a clinical history taking. How does the clinical picture manifest? Only the clinical signs and symptoms along with imagings will be used to diagnose hepatic encephalopathy in a cirrhotic patient. So you need to do a careful neurological examination to assess the mental status. So the mini mental status assessment, the mental status assessment, so many scorings are there. We need to use a careful neuropsychiatric assessment, followed by we need to assess the changes in memory, concentration, cognition, everything to be assessed, and West Evans criteria, Glasgow Coma Scale, and mini mental state examination. The mini mental state is, if you're going to look into that, it will be comprising a score, 11 questions will be there, comprising a score from 23 to 30, minimum to maximum. There are so many based upon the orientation, recall, language, so many things are there to discuss something about mini mental status examination. That is a separate area of discussion. Apart from that, so we need to look for the neurological, focal neurological findings. See, always hepatic encephalopathy, you need to diagnose HE only if you rule out the other possible causes. So hepatic encephalopathy is always a diagnosis of exclusion. If any patient in the background of cirrhosis comes to you with evidence of neurological comorbidities, neurological complications, a focal neurological deficit, doesn't mean that the patient is having evidence of HE. Always you need to think about the organic pathology which is happening in the CNS. So we need to look for the other subtle neurological motor abnormality that can also happen in a patient with hepatic encephalopathy, like hypomimia, which means a mask-like faces can be there, dysarthria, increased tone, articulation being improper, followed by ataxic gait may happen. These are all the other neurological features can be there in a subtle presentation. And apart from that, the deep pendant reflexes may be high, or maybe increased, and asterisks, as we all know that Mastrix is being characteristic in hepatic encephalopathy as per West Evans stage 2, but it can happen in other conditions as well. Well known, it can be a renal intoxication and other conditions also. It's mainly because of the agonist imbalance due to disturbed diencephalic motor centers. So once your diencephalic motor centers, if it is going to be disturbed, the asterixis can be a characteristic presentation, which most of the time during your clinical examination we will be eliciting. Once the asterix is being very clear, which means the patient is being progressing to hepatic encephalopathy stage 2, which is a very classical presentation most of the time when we are examining. And this is a outline what you have been discussing, the Parkinsonism features, hyperreflexia, hypertonia, altered sleep pattern, sleep latency, and fetal hepaticus. There is not much now in discussion on that, but fetal hepaticus also can be seen in some patients. If the patient is having high level of, because of excess ammonia load, the patient will be having attribute to a volatile sulfur compound because of a dimethyl sulfide, which is going to be identified in your breath. Sometimes in cirrhotic background, you can be able to identify a fetal hepaticus also. As we all know, the rare manifestations will always happen in case of hepatic encephalopathy, like hepatic myelopathy, which means a motor paraplegia, spasticity. Other things can also present, followed by few patients can develop a Parkinsonism, extrapyramidal signs and symptoms, which means balismus, hemibalismus, followed by and other symptoms also can be present. Mainly to discuss now, how will you recognize the patient with evidence of minimal hepatic encephalopathy? Because very easy to recognize the overt features, which means the stage 3 and 4, and the covert hepatic encephalopathy, a minimal hepatic encephalopathy will be most of the time will be unknown enemy, which means it will be very difficult to recognize, which means so how to define a patient with covert hepatic encephalopathy, which means when you're going to examine a patient in the background of liver disease, the clinical presentation will not be yielding much, and the neurological examination will not be yielding much by looking into the history, but only when you are going to subject the patient for a neuropsychiatric assessment or neurophysiological test. There are plenty of tests are there for a neurophysiological assessment. You can able to diagnose covert hepatic encephalopathy. So ASLD and EASL question statement, what they have been mentioning about, as we all know, covert hepatic encephalopathy will be there for 20 to 80% of the patient in the background of cirrhosis, and OHE starts with grade 2 with the evidence of asterixis and disorientation most of the time. So covert is nothing but a minimal hepatic with West Evans grade 1. So 20 to 80% of the patients can be there, and usually this covert hepatic encephalopathy can progress to hepatic encephalopathy, a florid hepatic encephalopathy, which means over stage 3 and 4 in more than 50% of the patients over a period of 3 years. That is the most important entity for me to discuss. And apart from that, there are multiple risk factors. Even after that, the patient is consuming alcohol, hepatitis B and C, and if the patient is having evidence of varices, which is not going to be there. If there is any precipitating factors which is going to trigger, the covert features can be developing into overt hepatic NCAF also. So what is the natural history of covert? It can be unchanged, it can be improved, it can deteriorate, it can develop a overt hepatic encephalopathy. Also, see, once a patient develops a covert hepatic encephalopathy, it's very disturbing most of the time because you couldn't able to lead a normal life. Your routines will be disturbed, your family life will be disturbed, your mentality will be disturbed, your social stigmata is going to come down, and there is high risk of mortality. You couldn't able to drive, you couldn't able to navigate, you couldn't able to concentrate in your work, and you will be having frequent falls. That means around 30 to 40% of the patient will be having a frequent falls when they are going for the routine activity, which will predispose to fractures. And most of the time you will be having social, unemployed status, followed by sleep disturbances, which will be there most of the time, and multiple nocturnal waking episodes will be there, and the memory and learning ability is going to come down. And most of the time you will be in social, stigmata. You will be most of the time will be having this kind of presentation that has to be recognized early by hepatologists when you're tackling a patient with covert hepatic encephalopathy. So this is a wonderful paper being submitted by Praveen Sharma et al. And the patient is going to present with a MELD of more than 15. And if the CF of that, I'll be discussing critical flicker frequency, if it is going to be more than 39. And we are going to measure the ammonia levels, if it is going to see the ammonia levels, if it is going to be more than 84. In this presentation, in the background, the predictors are being used for assessing a patient with minimal hepatic encephalopathy, the various predictors. So always, when you're going to diagnose a patient, we need to take a good history, a clinical examination. That's the most important thing. And there is no standard gold test for the diagnosis of hepatic encephalopathy. Even if you want to diagnose minimal hepatic encephalopathy, there is no single test, and there are plenty of tests. Every effort. See, always, I told you before, HE is always a diagnosis of exclusion. You need to rule out uremic encephalopathy. You need to work in terms of hepatic septic encephalopathy, and there's so many other complications. The neurological picture has to be analyzed properly before labeling the patient as hepatic encephalopathy. So, which means the lower grades of encephalopathy will be progressing to higher level of involvement, followed by changes in motor presentation and consciousness may be absorbed, and with progress in neurological deficit can set in, followed by, as I discussed with you, this is also one more test entity. That means there's a smooth pursuit eye movements if it is going to be involved. That's also one more clinical pointer. Now, that smooth pursuit of eye movements also can be assessed in the patient with the hepatic NCAF, and once the patient develops stage 4, these things and all will going to be impaired, and this data cognition and other complications also can be presented. So the deficit in attention, visual spatial abilities, fine motor skills, everything is going to come down. And always you should remember there are plenty of differential diagnoses for hepatic encephalopathy. You all remember alcohol intoxication. There are so many symptoms: delirium tremens, alcohol withdrawal, Wernicke's encephalopathy, or electrolyte imbalances. Always you should remember that. Hyponatremia, hypercalcemia can predispose, and hypomagnesemia, and drug abuse. If the patient presents to you with benzodiazepines overdose, opioids overdose, and type 2 diabetes, sometimes the patient will be having diabetic ketoacidosis, that will also predispose to cerebral edema. So these kind of presentations can all be ruled out in the differential diagnosis. Sometimes the psychiatric disorders. Better. Just a minute. And sometimes a psychiatric disorders also, some complications can be there. Also organ failure, acute kidney injury, or uremic encephalopathy and septicemia, and other complications can happen if the patient. Always you need to look for the differential diagnosis in a patient with hepatic encephalopathy. And this is about the diagnosis of minimal hepatic encephalopathy. There are plenty of tests being available, and the key intention for me to show what are the various components, and my intention is not to discuss each and everything. See, we need to know about the psychometric evaluation, which means there are so many tests. If you are in your daily practice, you'll be seeing number connection tests. We'll ask the patient to draw. We'll be asking the patient to draw the number connection. We'll ask the patient to trace the line. We'll ask the patient to block serial dotting and block designing, digit symbol. There are so many tests are available to analyze. If the patient score, if it is going to be less than -4, it is always diagnostic, and if it is going to be less than -6, it indicates a poor prognostic indicator. So this simple score can able to recognize most of the time the patients in covert hepatic encephalopathy couldn't able to proceed with that. And this is another interesting entity apart from psychometric evaluation like serial dotting, number connection, and digit symbol and all. This is another new entity about R bands. What do you mean by R bands? Is nothing but a repeatable battery and neurological assessment scoring system. That is also can be used. R bands can be used, but in this it's not much being used nowadays because it has been focused in two areas. One is based upon the cortex and another one is based upon the subcortex. Hepatic encephalopathy patients predominantly worse in the subcortical component. So this has to be practiced mainly by the psychologists, and that's the limitations of its use much, and it's been used in patients with schizophrenic and Alzheimer's patients. And there are so many other neurological tests like EEG, visual potentials, BERA, and critical flicker frequency can be used. And this one interesting, most of the time we'll be taking for a thesis discussion, this critical flicker frequency, what you're going to do, you need to flick, see what is going to happen to your retina. See, always we are knowing about something about diabetic retinopathy. What is it? Hepatic retinopathy, which means because of this astrocyte, which is going to swallow in case of cerebral edema, the retinal sites also is going to be involved, undergoing edema, followed by hepatic retinopathy is going to set in. In order to recognize the hepatic retinopathy, we need to flicker the light frequently, and we need to make the patient to sensitize how many episodes they can able to recognize the frequent light flickering, which means the threshold should be around 38 to 39 hertz has to be there. So if there is some drawbacks for this critical flicker frequency to be assessed, which means if the patient, the binocular vision has to be intact as a patient if it is growing old, and the patient is having some of the medications for, and the patient is having any glasses. These are all the a setback for this test. But even then, critical flicker frequency can be used in a easy bedside assessment, and no need for a psychologist. It's a short period of time consuming and minimal cost if you're going to analyze in a bed test. There are other computerized analysis like inhibitory control, cognitive research, scanners. Briefly, I will be discussing something about ICT. What is this ICT in the evidence of hepatic NCAF? See, always if you're asking the patient, if you're making, see, all this is based upon target and lure. What do you mean by the target and lure? Always you should remember, if you're asking the patient to identify X followed by Y and followed by X and Y. Suppose if this is not going to happen, if the patient is going to be X followed by X, means the patient has to stop there. X followed by Y means the patient has to stop there. So if it is not going to happen, if the patient is having difficulty in recognition XY rather than XX or YY, like that, if the patient is having difficulty in recognizing these things, which means this is also a very easier way to analyze your hepatic encephalopathy in an earlier presentation to identify the patient who is having covert features of hepatic encephalopathy. And we can do approximately around 40 attempts of this ICT. And this separate entity about covert hepatic encephalopathy can itself be asked as a short note for all the PGs to be discussed. And apart from that, the cognitive drug research and so many other things like the scan test can be used. And apart from that, the Stroop smartphone application system. So this is a new entity. What is going to happen if you're going to see in the right bottom? See, if you're going to see yellow, green, and red. The yellow has been plotted here as in blue letter, and red has been plotted in yellow letter. So the patient has to be identified the yellow component in blue correctly. So if the patient couldn't able to recognize this test in a digitalized fashion, if the patient couldn't able to recognize if the cutoff time, if it is going to be more than 190 seconds, there is a true smartphone application which is being easily downloadable in the net. So if the patient's cutoff time is going to be prolonged, which means the patient is going for evidence of hepatic encephalopathy. This is what has been shown based upon the Encephal app application system, which is being available, easily downloadable for most of the systems. This is nothing but a continuous reaction time. So what is going to happen? See, always this is based upon the decibel of sounds. How many decibels of sounds you are going to analyze? Based upon that, you need to respond to that. So minimum 2 minutes to a 10 minutes test. This is a basic instruction has to be done, and followed by every time at random intervals, we need to produce a sound at a rate of around 2 to 6 seconds. The patient has to identify the reaction time index. That's the main entity for identifying a patient with CRT index. So these are all the tests can identify the motor reaction, sustained attention, inhibited control, are all these are all the key abilities in daily life functioning has to be assessed. And apart from that, serum ammonia, nothing much about serum ammonia, but always elevated blood ammonia doesn't mean the patient is having hepatic encephalopathy, because it can identify, you can elevate in other conditions, uremic, also it can identify in urea cycle disorders, hyperammonemia disorders. I mean, so many other conditions are there. So always doesn't mean that elevated ammonia is a pointer for HE. That's the main thing. And how will you take ammonia? It should be in a vacuum, and the immediate samples has to be taken. And you should not, I mean, when you're sampling the ammonia, make sure that you should not use any tourniquet or restraints before taking a sample. You need to take a sample from the stasis-free way to identify the levels of serum ammonia. Lumbar puncture doesn't yield much, but in case of differential diagnosis of hepatic encephalopathy, we can use a lumbar puncture to identify any infections. And also the new entity of CSF glutamine levels, because as we all know that the glutamine can be increased in the patient with hepatic encaph. So CSF glutamine levels can be used to analyze, but this all doesn't going to determine the severity, doesn't going to determine the prognosis. So nothing much of use about these conditions. And apart from that, the SPECT analysis based upon the neuroimaging techniques, PET, CT, MRI, the diffusion weighted imaging, the attenuated recovery. There are so many things are being used in that. So SPECT studies can be used to identify the increased flow in the basal ganglia, but it's more expensive. And using a technetium tracer can be done, but these are all more expensive. This is a list of tests is available. The FLAIR sequence, which means fluid attenuation and inversion recovery sequence. There's so many sequence of tests have been there, and the magnetic integration and spectrometry. See, in this main thing I would like to discuss, we need to identify the peaks. So whether the peak of glutamine is going on, glutamate is going to be high, whether the myoinositol and choline signals is going to come down. So we need to identify everything. So based upon this scoring system, we need to categorize the patient. Suppose if the scores are normal, if you're going to do all these scores, if you're going to take at least 1 or 2 scores, if the scores are normal, wait and retest the patient for every 6 months to look for evidence of neurological abnormality. But if the scores are abnormal, which means the diagnosis of minimal hepatic encephalopathy is established, so you need to start the patient with basic line of therapy, followed by, based upon the clinical behavior, family history, friends history, mini mental status, examination. Based upon that, we need to categorize the patient with the possibility of MHE or unlikely to be a feature of minimal hepatic encephalopathy. These things and all to be categorized. So this is nothing but a simple questionnaire. What is going to use the 4-SIP questionnaire? Am I eating much less than usual? Am I maintaining balance? My routine physical activity, or irritability, or do I act irritably or impatient with myself? These are all basic questionnaires that we need to ask to analyze the patient with minimal hepatic encephalopathy. This is also the same thing what I've been discussed. So if we need to look for the basic test, if it is normal, then we need to redo the test again after a period of 6 months. If it is abnormal, then we need to label the patient with covert hepatic encephalopathy. So the remaining area for me to discuss right now, how will you treat the patient with hepatic encephalopathy? See, very important, because most of the time many physicians and surgeons, when have been discussing with us, so the managing a patient with hepatic encephalopathy is very complex and will be a tough one to tackle, because there are new innovations still happening. And out of the dose, how will you, establish the severity? Based upon that, we need to calculate the dose, and other management has to be there. And we need to look for the precipitating focus. Suppose if the patient in stage 1, and suddenly if the patient is going for stage 4 NCAP, we need to always analyze this precipitating focus of infection. It could be a nitrogenous focus, or it could be a non-nitrogenous focus. There are plenty of precipitating focus that I'll be showing in my upcoming slides. So always we need to identify the causes, other causes of hepatic encephalopathy, identifying the precipitating factor. We need to reinitiate the treatment, and always he keeps on assessing the patient every 72 hours. So if you made a wrong diagnosis, always do a imaging to reconfirm the diagnosis if you are missing something or not, and admit the patient, start the empirical regimen, and if needed, shift the patient to ICU to initiate the level of care. This is a basic outline. So always we need to look for the differential diagnosis of encephalopathy, whether the patient is hypoxic, hypercapnic, or whether the patient is acidotic or uremic or electrolyte disturbances or any alcohol mimics or any alcohol withdrawal effects, or if the patient is having any septicemia or cerebral edema because of any other focus. These are all the other causes to be assessed. And precipitating factors, always this is a very interesting area based upon the nitrogenous and non-nitrogenous compounds, whether the patient is having septicemia or GA hemorrhage or severe constipation or dietary protein overload, and so many other things are there, the list of things which identify the precipitating factors for hepatic encephalopathy, and followed by we need to initiate the treatment for hepatic encephalopathy. That's the first line. This is a basic outline about initiating the treatment of hepatic encephalopathy. There's so much of drugs are being tried in the field, but the final line of treatment, once a patient goes for stage 3 and 4, is hepatic transplant to be considered for most of the patients. And this is a basic outline how the various drugs is going to act, like flumazenil and lactose, urea cycle pathway drugs. And apart from that, there's so many LOLA, BCAA, and other drugs. How does it going to act? That have been shown in the diagram. And apart from that, as I discussed, we need to eliminate the precipitating factors, treat simultaneously. If the patient is having GA bleeding, start the patient on blood transfusion, NG lavage, nasogastric lavage has to be done, infection control well with antibiotic. And if the patient is on any medications like benzodiazepine, stop it, correct the electrolyte disturbances. Constipation will be very significantly relieved because that's a significant precipitating factor for hepatic encephalopathy. Renal failure means always albumin can be used in the management of renal failure and sometimes dialysis. And these are all the main intention for me is the medical management for hepatic encephalopathy. That's the main thing. It's hyperammonemia has to be bring down, has to be reduced. So one is by the diet, and one is by the catharsis and by antibiotic support. And there are many drugs for ammonia clearance now. If you want to try enema, once the patient is stage 3 and 4, where the patient couldn't able to take much oral, we can try enema, but there is a difficulty in placing the patient. We need to take the patient frontal neck position, left lateral decubitals, and so there are so many. But if you're going to use lactose, you can think you can use at the dose of around 300 to 700 in 300 ml and 700 ml of saline can be tried, but the cost is slightly more, and the difficulty is sometimes the patient can go for dehydration, sometimes the patient go for ileus, and sometimes the patient can go for other complications to set in. Always the enema is a questionable issue when tackling a patient with hepatic encephalopathy. And apart from that, nutrition is the most important entity to be taken care of. See, why means protein restriction. What's going to happen? Protein restriction, if there is evidence, is usual as the decrease in nitrogenous load. See, we need to target a protein approximately 1.5 to 2 kilograms per kg per day, and your calorie intake approximately around 35 to 40 kilocalories per day has to be maintained. And that is the main thing if you're going to substitute the patient. So always you need to use a vegetable source of protein, and rather than using those main vegetable source of proteins is the most important thing. BCAA and other supplementation also can be considered. So why you need to consider vegetable proteins, which means it predisposes to high fiber load and decreases the colonic pH, and it improves the colonic motility, and purgation, other things is going to improve, and colonic pH, if it is going to come down, ammonia absorption will be reduced. So ammonia absorption, if it is going to reduce, the pathway of hepatic encephalopathy will be definitely going to come down. This is about branch-chain amino acids. As we all know, valine, leucine, and isoleucine. These are all the branch-chain amino acids can be used. Nowadays, branch-chain amino acids can be considered also in the management of hepatic encephalopathy at the rate of around 0.25 grams per kg. See, what is the main role? If we are going to use BCAA, it will be converting to glutamate and followed by the ammonia. So this will be useful. This glutamine, what is going to happen? It will prevent sarcopenia. This glutamine is going to accumulate in the muscle. So these cirrhotic patients who are already having a low BCAA, to prevent sarcopenia and other complications, we need to substitute the patient with BCAA and other drugs. The main area what we are going to use is it's a non-absorbable disaccharides. As we all know that the lactose is semi-synthetic, non-absorbable disaccharide that we very frequently use, lactose and lactitol. So our intention when you are going to use lactulose, so much of important effects are there. So what is the basic mechanism of action? We frequently ask most of the time. So what is the basic mechanism of action? So it is having your major mechanism, like you all know, it's cathartic. So it is predisposing for a laxative effect. It's going to eliminate the ammonia. That is one thing. Second step is reduce ammonia synthesis and absorption. How? So in the intestinal bacteria, it is going to convert to acetic acid. If you're going to look into the diagram, in the through the intestinal bacteria, it's going to convert into the acetic acid as well as lactic acid, which is going to reduce pH, which means the acidic media is going to, this decreases the synthesis and absorption of ammonia, which increases the movement of ammonia from blood to the GIT. So what is going to happen? The blood, from blood to GIT, the ammonia is going to move out, and also the lactose, if you're going to see in the colon, when it is going to combine this ammonia, if it is going to combine with hydrogen ions, because of increase in the level of colonic lactate, the hydrogen ions is going to combine with NH3, the ammonia, which will form the ammonium ion. So it is non-absorbable. So once ammonium ions forms, it will be eliminating, and it will also promote the growth of non-urease producing bacteria, beneficial bacteria, so many other things. It will also involve in gut dysbiosis. So for maintenance, other things has to be done. So these are all the major mechanism steps of lactulose and lactitol. So we need to give at a rate of around 50 to 30 ml, around twice, 2 to 3 soft bowel movements. We can give it twice a day or twice a day. It depends upon the clinical presentation. And sometimes if you want, you can go for lactulose enema. Always the bloatedness, sometimes over treatment, sometimes electrolyte disturbance can set in if you're going to use lactulose. But there are certain pros and cons for using lactulose. So as we are discussing about the pros, the clinical anecdotal experience and comfort with the use of lactulose are being there, as well as regarding the cons, the beneficial effect, and moreover the risk of no improvement of overt hepatic encephalopathy is still being there when you're going to use lactulose for a longer duration of therapy. Apart from that, these are all the various trials for lactulose being tried, and what are the various antibiotics can be tried in the management of hepatic encephalopathy, like neomycin. So this all will act on the reduce the levels of ammonia. So how does it act? Neomycin inhibits the intestinal glutamase, reduces ammonia, but neomycin we are not using much nowadays. Metronidazole can be considered, paromomycin and vancomycin can be considered, but these drugs are not much of use nowadays. It's not in the main mechanism of use right now in the management of hepatic encephalopathy. But the main thing is rifaximin. It's one of the, it's a semi-synthetic drug, and it's also disaccharide non-absorbable, which can be used as a minimally absorbed with a high barrier. So if you're going to use rifaximin in the treatment of hepatic encephalopathy, we need to use at the dose of around 550 milligrams. And if you're going to use rifaximin in the management of hepatic encephalopathy, always you should remember that how long you're going to use. Some studies are mentioning about 2 to 3 months. Some studies are mentioning about up to transplant consideration, and even the prevention of primary prophylaxis, in the prevention of secondary prophylaxis, how many days you're going to use rifaximin. There are so many questions that are still being there. If you're going to use rifaximin, whether there is any possibility of drug resistance. So if it's mainly based upon the DNA polymerase effect and RNA dependent DNA polymerase. So if there is any inhibition or any pathway is going to interrupt in the management of rifaximin, that is also can predispose. So if you're going to use rifaximin, it will act on both gram positive, gram negative, anaerobes, aerobes, everywhere it's going to act. And moreover, some minimal side effects like flatulence, abdominal pain. And if you're going to combination therapy of rifaximin and lactulose, the beneficial effects of hepatic encephalopathy is dramatically very high. That has been proved in multiple trials. And apart from that, the multiple ammonia scavengers can be used like LOLA, LOPA, L-ornithine L-acetate, L-ornithine phenylacetate, L-ornithine I mean, butyl acetate, so many phenyl butyrate, so many other components being tried nowadays. See, these all the components is going to be involved in the urea cycle pathway of ammonia metabolism. So it will prevent the formation of glutamine, and it makes the synthesis of urea, which is predisposing, which will be predominantly eliminated in your urine. So what is going to happen? So it increases the carbonyl phosphate. If you're going to see the urea cycle, when you're going to subject the patient, so either you're going to give 5 grams or 10 grams, what are the dose if LOLA, if you're going to use for a patient, it is going to increase the urea production by producing increased carbonyl phosphate synthetase. And most of the time we will be preferring IV route rather than going by an oral route. And sodium benzoate also can be used nowadays as ammonia scavenging, but still many more studies to go on with about the beneficial effects of sodium benzoate. And this is the outline of the diagram, how the basic drugs like sodium benzoate as well as LOLA and other drugs is going to act over the pathway of increasing levels of urea as an ammonia scavenging effect. And apart from that, like sodium phenyl butyrate, the main thing, every drugs is going to be used in the urea cycle pathway, and glyceryl phenyl butyrate, sodium phenyl butyrate, so many drugs been tried. L-ornithine phenyl acetate can be tried, but these are all still in phase 2 or phase 2B studies in decompensated cirrhosis for a patient with overt hepatic encephalopathy. So these are all one more drug which is being tried, like a spherical carbon absorber. See, this is what is that? It's mainly been used in Japan. What is this safe? But what they are going to do, it binds with around 600 kilograms per meter square. What they've been tried, the external surface area of contact. If you are going to use a spherical carbon absorbent, what's going to do? It binds to very small molecules in your gut. So it will be acting in TNF pathway, lipopolysaccharide, eliminates the endotoxin, and it is going to block the absorption. It is also having ammonia lowering properties, but these are all still in phase 2 study. And polyethylene glycol nowadays, many patients are being considered around the 4 liters dose of PEG, but polyethylene glycol, the adverse events, it can be having a renal predisposition side effects, and next to that, the dehydration can be there, and you can't use the patient with PEG for a longer duration of time. So these are all the adverse events when you are going to use a polyethylene glycol. So this is about the basic regimen, about various doses what we are going to try, like sodium benzoate at a rate of 5.5 grams per meter square, and glyceryl phenyl butyrate 5 to 12.4, and AST, which means nothing but AST 120, which means spherical carbon. If you're going to use, there are so many things which mean charcoal powder, everything has been trial in the management of hepatic encephalopathy. And regarding the newer line of therapy, zinc can also always be considered in the management of, because it's a cofactor for urea cycle, can be added to the therapy, like already we have been using in the main primary condition of Wilson's. And also you can consider albumin, because what is going to happen, the newest studies, what they may mention, if you're going to frequently give the patient with albumin therapy, at the rate of around 20% of albumin, sulfoalbumin, if you're going to substitute the patient, what's going to happen? And the inflammatory pathway is going to come down. The interleukin toxicity, the tumor necrosis factor pathway activation, the circulatory overload, and the predisposition of the patients to cerebral edema, the increased levels of MAV, the cerebral perfusion, pressure, the maintenance, everything is going to improve well with albumin substitution for the patient. So nowadays, what they've been substituting, always you can combine albumin with lactose in the management of hepatic encephalopathy. Also, flumazenil, as well known as a benzodiazepine antagonist, can be considered, but the longer trials is still not more validated. And hyperalimentation, that's what I've been discussing. Hyperalimentation in the form of calorie of around 35 to 40 kilocalories per kg per day, followed by proteins around 1.5 to 2 grams of protein kilo. Now, always you should not restrict the protein more. Suppose if the patient is having very severe overt hepatic encephalopathy, at that point of junction, we can restrict the protein minimally. But if you're going to restrict the protein more, what is going to happen? That will also predispose to less of glutamine formation in your muscle, will be predisposing to urea cycle, will be predisposing to sarcopenia and other complication can set in. So always you should not restrict the protein too much. And apart from that, GABA, GABs are like GABA antagonists can be tried. These are all the other new molecules of trial in trial. And fecal microbiota transplant, as we all well know, if you're going to use a capsulated form of fecal microbiota transplant, also can be considered like what you're going to use in the management of alcoholic hepatitis and other therapy. Like even for hepatic encephalopathy, we can try FMT, like what you're going to try FMT in antibiotic associated colitis and other conditions. And always say FMT, what is going to happen? You all should remember the gut dysbiosis is well-known fact in predisposing etiology of hepatic encephalopathy. If the patient is having gut dysbiosis, the streptococcus and other bad bacteria levels is going to flourish, the Clostridia levels is going to be high, the Firmicutes and other protective bacterial levels is going to come down. So this fecal microbiota transplant is definitely having a beneficial role, but the studies and other things that should be validated, which will be playing a role in gut dysbiosis to prevent the pathway. As we all know, the gut dysbiosis, the bile acid and other pathway like hyperalimentation, so many other pathways being involved in the pathogenesis, not only about hyperammonemia to be discussed. And probiotics, many probiotics, it can be probiotic, prebiotic, or symbiotic, many probiotics can be tried, but not much of evidence in the management of hepatic encephalopathy. And what is the form of probiotic? Even lactobacillus form, even Saccharomyces form. So even what are the form of probiotic if you're going to use the beneficial effect, bifidobacterium, is still a questionable issue. As you all know, it's a living microorganism which alters the intestinal balance of microflora in the gut. So probiotics also can be considered. The combination therapy with rifaximin, lactose, that what I've been discussed, also been considered. Regarding the surgery, what you're going to do, if you're going to look in pain with the portosystemic shunt and other problems, we need to close the shunt. So portosystemic embolization is one therapy. Percutaneous transhepatic obliteration or percutaneous transhepatic sclerotherapy. There are newer innovations which is being used in the management. See, if you want to do a percutaneous transhepatic, you need to use a sclerosins. That can be tried in the management of hepatic encephalopathy, and transhepatic obliteration can be done. And one more thing, like BRTO, as we all know, BRTO is well known. It's a balloon retrograde transvenous obliteration. So BRTO, if you're going to use in the management of fundal varices, that BRTO can also be used once the fundal varices, everything is going to control well, followed by the hepatic encephalopathy episodes is going to come down. Even many newer guidelines, they have been mentioned about the role of BRTO to bring down the episodes of hepatic encephalopathy. These are all the various surgical, like portosystemic shunt procedures, transcutaneous percutaneous transhepatic obliteration, sclerotherapy, BRTO, many things can be considered. Post-chips HE, no role of any drugs. We need to choose the diameter. Suppose if you are going to use the diameter of the stent, what is 4 tips? Is nothing but a transjugular intrahepatic portosystemic shunt. So, what is the, I mean, if you're placing a if you so suppose if you're going to plan the patient for tips, if you're going to establish a connection between the hepatic and the portal vein, so what is going to happen? The post-chips, the patient is going to develop hepatic encaph. There is high possibility for the patient to go for hepatic encaph because of the stent diameter. And only when you're choosing a good stent of around 8 to 10 millimeter of size, that's the main thing to prevent the post-chips and other complications. And secondary prophylaxis, always to be considered, but the duration, how long you're going to give until the patient consider for liver transplant or any other thing. The combined lactose and rifaximin therapy can be tried. And for primary prophylaxis, no strong consensus data has still been established. And for the prevention of after tips, always based upon the stent diameter, other things to be assessed, and no proper drugs for the primary prophylaxis has been accepted in the management of hepatic encephalopathy. So usually it is indefinitely to be given, but the duration is not being controlled. Some patients being used for 2 months, 3 months, 6 months, these therapies, but unless and otherwise, if the patient is having autoimmune hepatitis, if you're going to put the patient steroids, antivirals, if you're going to treat the patient, this secondary prophylaxis is going to improve very well. And as a patient, every complication is going to come down, then you can stop the secondary prophylaxis. Otherwise, indefinite prophylactic therapy has to be considered for most of the patients. And obviously, like Prometheus system, MAS, albumin dialysis, so many other things can be considered, but these are all a questionable issue in the management of hepatic encaph. Stage 3 and 4, artificial liver support can be considered as a bridge, but liver transplant is a final entity to be considered in the patient with hepatic encephalopathy. And before concluding, the few points to summarize in my discussion, If you want to tackle the hepatic encephalopathy properly, with the clinical history, assessment, the scoring systems in your clinical practice, analyze the patient well, always rule out hepatic encephalopathy, make hepatic encephalopathy only as a diagnosis of exclusion, rule out all the primary focus, treat all the precipitating causes, and look for the identifying focus, like what is the etiology, what is the trigger, and where is the presentation, is there any evidence of focal neurological signs and lesions, do a basic workup, if needed, do imaging and other things, the clinical assessment, and admit the patient in a proper center and proper level of care, refer the patient promptly to the gastroenterologist regarding the therapy to be considered, and apart from that, the first line of care, lactose and other cathartics to be initiated, followed by eliminating the precipitating focus. Rifaximin can be considered, and bioartificial support devices and other mechanisms, other multiple modalities of drugs, and consider the patient early for liver transplant once a patient been diagnosed with covert features, because within a period of 3 years, there is high possibility for the patient to go for overt hepatic encephalopathy, and most of the time we couldn't be able to revive the patient even after liver transplant. The patient can go, sometimes the patient may succumb to die, and always you need to take the presentation at the earlier point of time to tackle this effective hepatic encephalopathy in the right way. With this, I would like to rest my presentation, and I'm very happy to take up your questions if anything is there to share upon. Thank you all.
Excellent talk, Dr. Arun.
Thank you, sir.
So, as a neurologist,
is there any questions to take?
Yeah, Arun, I like to talk about a neurologist perspective in hepatic encephalopathy.
Yes,
most
yes.
of the time, I would
I'm
say
waiting
around,
for
I would say more than 90% of the times, the first encounter of a neurologist with a hepatic encephalopathy patient will be mostly in an ICU. So we have been called in for a patient who is drowsy, maybe stuporous, maybe in deep comatose state, and we have been called in to assess neurological status. So in a drowsy patient with a clinical setting of a hepatic failure who has an astraxis, the diagnosis is going to be straightforward. And we use EEG for two reasons. One, to look for transients. There are two types of transients that we will look. One, is there a triphasic wave? And second, there is intermittent delta activity. So these are the things that we look at EEG. And one more thing, what we look at is any overt EEG's electrical signs of a seizure. Because non-convulsive status, they can present with seizures. So these are the three things what we'll be looking at in EEG. And most of the patients, we will look for a brain imaging, though MRI will give us more information. Practically, CT is the one which is practical. The reasons are, number one, most of the patients with hepatic dysfunction will be having some coagulation abnormalities, so a bleed has to be ruled out. Number two, the logistic issues. The patient may be drowsy, and we will not be able to give sedation because it might again precipitate this. The sensorium will be down with the sedation. So, and then intubation, intubated patient, it's the logistics will be difficult. So CT is the preferred one initially to look for to rule out a stroke or other structural disorders. So this is straightforward. But then in case of a covert hepatic encephalopathy, it's not that easy because the patient comes in a preclinical status. So here we need to be a bit more, most of the time, either the patient will complain of some attention deficits, maybe fatigue, maybe disturbed sleep. These symptoms are very, very subtle. And maybe the patient might not complain. Maybe the relatives may be the one who have noted those and brought the patient to us. And most of the time, there will be not much clinical findings. So we should be looking at psychomotor testing, mainly for attention, executive functions, visuospatial disorientation, psychomotor speed. And these are the things that what we'll be looking at in a patient with an covert or preclinical hepatic encephalopathy. And in any patient with hepatic encephalopathy, the things what a neurologist will be looking for is one type, grade, whether it's episodic, whether it's recurrent or chronic, and whether it is a spontaneous one or is it precipitated by something. In a patient who doesn't have much of hepatic failure, but still we suspect hepatic encephalopathy, we will rule out other things, like it's a diagnosis of exclusion there. In a patient with hepatic encephalopathy, I will be very careful with CSF analysis, because especially in a patient who has an acute deterioration, because the raised ICT is more common with acute hepatic encephalopathy. So raised ICT, do LP, it's going to be catastrophic. And most of the time I read, there's a recent knowledge for me that raised ICT and ammonia levels correlates well. That if it is more than 200, then the patient, most probably the patient has a raised ICT. And will be, and especially in a patient with an acute hepatic encephalopathy, and also hypomagnesemia and hyponatremia these are the associated things with hepatic encephalopathy, which can add fire to the basic problem. With that, a neurologist perspective with that, and the treatment is obviously you are going to take care. We usually give an antiepileptic medication. I think the remaining treatment part is yours.
Thank you. Thank you very much, Dr. Prabhash, for enlightening discussion about hepatic encephalopathy neurological perspective. And what you said is absolutely true. Definitely, any patient who presents to us with neurologic deterioration and other complications to be assessed properly before labeling them as hepatic encephalopathy per se. The most important entity, because non-convulsive status, as what you're told, is absolutely true. Most of the time, many patients can be landing up, and alcohol withdrawal effects also to be analyzed properly. What you're saying is true and absolutely accepted. Thank you, doctor. And is there any questions for us to chat right now, sir?
Yeah, there are a few questions. Okay, number one, the role of PPI in hepatic encephalopathy.
So, role of PPI in hepatic encephalopathy. Actually, this is PPI in GERD is well known. The role of PPI in hepatic encephalopathy. The problem is what is going to happen if you're going to use proton pump inhibitor. Recently, I've read a paper about the usage of proton pump inhibitor. What is going to happen? It is going to alter your gut microbiota. So once a gut microbiota is well-known pathophysiology for hepatic encephalopathy to be discussed right now. So if the gut microbiota is going to be perturbated, if the gut microbiota is going to be disturbed, so the patient can be having worsening of hepatic encephalopathy. So most of the time, if you're going to use PPI as a diet dose, if you're going to suspend use of PPI for a long duration of time, that dysbiosis will be setting in. So the chances of worsening of hepatic encephalopathy is still high. But there are some PPIs which will not be having this kind of, like rabiprazole, actually, which is being not much of a potential toxicity to cause hepatic encephalopathy. But apart from that, the role of PPI is a questionable issue, not to be used in patients with hepatic encephalopathy.
The next question, what they have asked is, what is the LOLA dose?
LOLA. L-ornithine, L-aspartate, dose of LOLA, what we are going to start with, multiple studies have been giving various doses. Some patients have been receiving 5 grams in 250 ml of saline for a period of around 2 to 3 hours will be giving, and some patients will be giving around 10 grams, and some patients will be giving at around 20 to 40 grams also can be tried. But initially 5 grams in 250 ml of saline, what's being used thrice daily, most of the time will be, most beneficial effect in preventing the patient to progression of hepatic encephalopathy. So that's my experience. 5 grams or 10 grams I'll be combining for most of the patients, along with albumin and lactose.
The next question is, how common is covert hepatic encephalopathy?
I think I have discussed in my initial slides that covert hepatic encephalopathy rather than overt will be very tough to diagnose, and most of the patients in the background of cirrhosis will be having evidence of covert hepatic encephalopathy. Around 20 to 80% of the population can present with evidence of covert, rather than around 30 to 40% can be presenting with the evidence of overt hepatic encephalopathy. So most of the time covert is difficult to recognize, but many patients usually present with evidence of covert hepatic encephalopathy in the background of cirrhosis.
Next, okay, this is not related to this topic, but still I don't think any webinars will not be completed with this question, that what are the COVID-related liver problems?
COVID-related liver problems, there are many professors, senior consultants, I think, been discussed about that. See, if you're going to discuss something about COVID-related ever problems, the direct effect on hepatic encephalopathy, it's not much. Rather than what is going to happen if the patient is having COVID problem, the patient will be having alteration in your enzyme levels. The AST level is going to be altered. The ALT level may be altered because of the sepsis, because of the SARS-CoV, CoV2 receptors being involved. And the patient will be an alteration in enzyme levels. Sometimes the patient will be having evidence of jaundice, and sometimes the patient will be having evidence of inflammatory septic pathway is going to be activated, which will predispose the patient with multi-organ failure. It sometimes can predispose to hepatic failure, and also some patient can present with colitis. These are all the various GI pictures that in the background of COVID. But this kind of presentation, once a patient is going for multi-organ and other systems going to be involved, and ACL of acute and chronic liver failure and other pathology also nowadays being reported new entity. Once a patient is developing these kind of complications, there is a possibility for the patient to go for hepatic encephalopathy.
And the role of CS of lactulose.
CS of lactulose.
Lactulose, yeah.
Lactate, sir.
Lactulose.
CS of
Lactose levels. Lactose levels. Lactate levels. Yeah, I'm sorry. CS of lactate. I think it's a spelling mistake there. CS of lactate.
CS of lactate, see, actually, so what we've been discussed initially, the role of CS of glutamine has been well established to diagnose a patient with hepatic NCAF. CS of lactate also been used, but not much in hepatic NCAF. If you are going to suspect a septic focus, so your area to discuss, if you are going to suspect a septic meningitis or other focus, if the CS of lactate, if it is going to be more than 3 millimoles, so the patient is having evidence of septic meningitis or encephalitis is still high. But hepatic encephalopathy also, if you're going to look for CS of lactate levels, the ratio will be around more than 2 or 2.5, 1.5 to 3. But these are all subjective variation, and moreover, it is not been well yielded in the trials to be discussed.
I think one more question is there. Normal CPP.
Normal CPP. So normal cerebral perfusion, the maintenance, we need to take care of the intracranial tension when the patient with managing a patient of cerebral edema, and we should always maintain the CPP at a rate of around 60 to 80 millimeters of mercury. That is a maintenance of CPP, and we need to tackle the intracranial mean ICT. Intracranial pressure has to be maintained when you're managing a patient. Always you need to target the MAP. The MAP has to be raised in a reasonable way, with of albumin and other support. And these are all the main thing if you're going to manage a patient with the ACL of any acute liver failure, and the patient, if you're going to manage with other complications, always we need to manage when the patient is having evidence of hepatic, and the CPP, normal CPP should be around 60 to 80, which is the target to be maintained most of the time in to prevent raised ICT.
I think that's it. Questions are done. I think no more questions.
Any other questions to be involved?
Is there no more questions? Shall we close the talk today?
Yeah, thank you very much, Dr. Prabhash, and thank you very much, the respected audience and other consultants who have been who are going to be part in this program. And even in this post-COVID, even in the COVID season of our own doing this pandemic. But even then, if you are spending most of the time with us, and thank you very much to logging into the session. Thank you, Dr. Prabhash.
Thank you. Thank you.
Thank you very much.